Would request Dr. Anish Chandrana to please invite the speaker for this talk.
Yeah, good afternoon, everyone. And we have been into a very perfect discussion on heart failure in the previous session. Now, I think moving little further down in terms of prevention is concerned, I invite one and only my dear friend, Dr. Jagdish Hiremath, to please come on the dais to talk on turning the tide against heart disease. We all have known that India is a country where more than 35% of heart attack happens before the age of 50. And out of total death, which happens because of coronary artery disease, 1/4 are in quite young age. So I think we need really huge, robust and comprehensive efforts. And to enlighten us on this topic, I invite Dr. Jagdish Hiremath. Sir, please.
Thank you. Thanks for the invite. It's always a pleasure to be near Sabarmati. You see, the level of evidence goes by like this. In mathematics, it is 1A, physics, chemistry, biology, the medicine that we practice, social science and philosophy. It goes down to 2D. And anatomy, physiology, biochemistry, medical, and prevention actually has the least evidence related to that. So I have the freedom of divulging into something which I feel is right. Pardon me for that, but I feel the message will be loud and clear that we need to prevent. We all know that, but we'll know some guidelines related to that. Of course, preventive cardiology is a proactive, patient-centered, in which the clinician, team of clinician, non-clinician, assess the cardiovascular risks and implements a comprehensive strategy of risk mitigation to prevent cardiovascular disease and its clinical consequence. That means we have to first assess the risk, which is so difficult in India. There are no scores at all which we monitor really. I feel the Q-Risk-3 score, which is really a British score, it has a lot of Indian patients were involved in managing the score. If at all you want to use, I never use a risk score at all. So it's interesting to see how the transition of cardiovascular mortality takes place with affluence of the countries. For example, in African countries today, there will be famine and pestilence. That means 10% deaths in cardiovascular disease, that too lot of rheumatic hearts. And the remaining are infections and Chagas disease and things like that. This is what kills the patient with cardiac patients. The second step is where maybe some Middle East countries, maybe Pakistan, they are the countries wherein you 10 to 30% deaths due to cardiovascular disease, and they die of increased salt in the food. There is no awareness, the hypertensions are not diagnosed, and they die of intracranial hemorrhages. And of course, the residual infective things continue. Whereas the third one, where India is today, is degenerative and man-made disease. 30 to 60% of the CVD deaths are due to lifestyle diseases like what we know, diabetes, blood pressure, and maybe atherosclerosis. Europe is here, delayed degenerative, below 50% cardiovascular disease. Their community awareness, they did a lot of work towards prevention, and that's why they have moved into reduced smoking, cardiac diet, regular weight, and that's why their deaths are due to old age disease, Parkinson's and dementia and stuff like that. And fifth is where the USA is today probably. We've gone through all this, and now there is social appeal, mass shooting and bombing. This is what takes place there. So we are here, and we should now know that we must attack the lifestyle diseases with a lot of science involved in it, but a lot of thought process involved in it. And look at the achievements in public health in the 20th century. It's only up to 2000. Beyond that, graph will still go down. Total cardiovascular diseases after about 1960 or so started going down. Disease of the heart going down. Coronary artery disease going on. Strokes going down. And this is somewhere where the statins came onto the scene. And of course, social awareness, smoking and all this thing happened in United States. So a new medical graduate today in USA doesn't want to be an angioplasty doctor. He wants to be a CRT express, electrophysiologist, because that is where the market is. So coronary artery disease going down. I hope this happens to India because it's such a phenomenal change that it saves a lot of health expenditure, and India can save a lot of money and spend it on ISRO. So where is India today? India, urban is here, and affluence, urbanization, education is on the x-axis, and all these hypertension, lipids, diabetes are on the y-axis. So as affluence, urbanization and education goes on increasing, all these things go on increasing, then the countries form a summit and then start going down, like what has happened to Europe, North America, Australia, and New Zealand. India is on the upswing. Maybe in the next 20-25 years, we'll have a lot of cardiovascular disease, and then hopefully we'll start going down. My idea is today, for our own sake, our individual sake, our families, our social group, our WhatsApp group, can we start the downward journey on our own? It's possible. Maybe the entire society may not happen, but every doctor can represent a role model of health and then start working on this, and it will result into a downward journey from here. Another important factor here, see, Russia was merrily going along with these 4 countries, but suddenly 1993, Gorbachev happened to Russia. And suddenly you can see that it's gone up. So that means social stability also matters a lot. And that's why it is important to have a very stable government and other things. So chronic stable is a hard atheroma, you all know very well. Suppose this atheroma was not to be formed, is called primary prevention. Second is where it forms a thrombus where it breaks, forms acute coronary syndrome with lot of platelets and a few red blood cells. And it completely forms a red blood plug, that is a myocardial infarction. So the basic thing is a chronic atheroma which breaks and finally leads to events. So preventive strategies would be a major change in small community versus minor change in major community. For example, you do 300 angioplasties in a year, it is a major change in a small community. But you reduce the incidence of smoking in Ahmedabad by 2%. It will save you 500 angioplasties. So that's why preventive strategies are like that. Introduce a small change in the community and you will find the results, whether it is diet, whether it is exercise, whether it is all the talks that we go on, smoking and other things. So there is primordial prevention, primary prevention and secondary prevention. So I would say that suppose you want to alter the genes and the person is born with a smaller risk, is called primordial prevention. Suppose somebody is born with some genes, prevent formation of atherosclerosis is primary prevention. Suppose somebody has atherosclerosis today, preventing ASCV event is the secondary prevention. And this is my own strategy of preventing recurrent events would be tertiary prevention. So all these 4 types of preventions are possible and we'll just delve into them in the next 20 minutes. So primordial prevention, actually what is to be done is genetic mix. The Indian strategy of marrying in the same gotra and all is not correct. In fact, there are Indian communities where they absolute no for the same gotra. So that's a correct scientific strategy. And that's why we should be avoiding, rather encouraging intercaste marriages and other things, because that will lead into genetic mix. Lifestyle has a little role to play here because a person is not to be born with a disease. So it's only those who have family history should be careful, like in marriage's time, you can ask the history if there is arranged marriage and things like that. My surgeon friend from Pune, his son got married to a Japanese girl, Shoko. So this is really genetic mix, and I'm sure the genetic mix brings down the overall atherosclerotic incidence in this and in their next families, next generation. So this is a 38-year-old man who's undergone a bypass surgery. You can see the oxygen line here, and see the dense arcus juvenalis in it. This is arcus juvenalis, which means his LDL levels were 260, and this kind of a patient were in a rapid, progressive, aggressive atherosclerosis, premature atherosclerosis. And one Yemenis girl was sent to us for aortic stenosis, but actually her problem was a autosomal type of a hyperlipidemia. All these xanthelasmas over there, tuberous xanthomas and xanthomas here. And actually her aortic stenosis was also related to this deposition of cholesterol in her aortic valve. So a lot of controversy related. She was 9 years old. I sent her back to Yemen. I didn't treat her aortic stenosis also. Controversial, but okay. So the metabolic and diabetic related risks that we have, I call this central obesity as a metabolic sin, not as metabolic syndrome. See here, it is a metabolic sin because you can prevent it from the beginning, and if at all you have it, probably you can control it as time goes by. So these waist circumferences, and you know them very well, But metabolic syndrome not only increases the atherosclerotic risk, but can also lead to multi-organ system dysfunction. It's not the bad looking paunch, but it is the fat which gets deposited on the pancreas, leads to a less powerful or less quality insulin and triglycerides and other things that follow with it. There is a concept of thrifty gene. This is by Dr. Yajnik from Pune. What he says is, or Barter's hypothesis maybe, a child is born underweight because of various reasons, and the grandma thinks that this should be fed well and let him be normal boy at the time when he goes to school. So an underweight boy is fed so well that at the end of age of 5, when he goes to school, he's probably a little obese. And the thrifty gene that has inside cannot handle this overfeeding in the early ages. And that finally leads to metabolic syndrome, early diabetes and other things. So that can also be prevented. It's a very simple thing to remember. So let's come to now from primordial prevention, come to preventing atherosclerosis, that in formation of atheroma plug. This is by maintaining targets of risk factor like diabetes, weight, blood pressure, high LDL cholesterol. It's also related to lifestyle change, because lifestyle change will make a difference here. Generally, a 75-year-old comes with triple vessel calcific disease, and the family asked me, what is the dietary control that we should offer? I said, you in the 40s, you go for dietary control. Let him eat very merrily, or at least don't be so strict about his diet. Statin and aspirin only in special cases. Aspirin is not to be used for primary prevention in ladies, and aspirin in primary prevention in men also in very select high-risk patients, not otherwise. So aspirin, which was a bane of everything initially, now is slowly waned off, and now it is to be used. The statin becomes even a drug for primary prevention. So whether it is diabetes, tobacco, all these other factors you know very well, but I want to bring to you some other risk factors like vitamin B12 or homocysteine deficiency, vitamin D, LP little a, pollution, type D personality, sitting in one place for more than 2 hours. Sitting is akin to smoking. So if you want to do that, I think we should do work on the sitting part also. Periodontitis, hypercoagulable state, frailty, CKD and high heart rate. All these are risk factors, and one can work on them to achieve primary prevention. Non-compliance of medication. Somebody is a diabetic, doesn't take medicines well, hypertensive, doesn't take medicine, is non-compliant to it, then his risk is very high actually. And this is pigmented knuckles, giving high B12 level. He's a rich man, golden rings in his fingers, but obviously he's purely vegetarian and B12 deficient. Vitamin D is there between 11 a.m. and 3 p.m. gives you the vitamin D dose, not the early morning. So we should all be aware, and maybe how many of us can go 20 minutes of sunbathing 11 a.m. to 3 p.m.? I don't know. So it's not practical in India. So despite being in a sunny country, we have such vitamin D deficiency. How it contributes, it doesn't matter. My thinking is it's a simple thing to correct. Why is it called vital amine? It has some vascular implication. Correct it. It's easy to correct that way. Pollution is now clearly recognized as one of the factors. In Pune, there is an area called Null Stop, a very busy area. There, all sparrows have disappeared from there. Because I say that the sparrows know that pollution is a problem, but human beings don't know that pollution is a problem. And there have been, this slide is just to show you that there is a lot of research related to pollution. I don't want to read through the slide. Sitting is akin to smoking. Avoid sitting for more than 2 hours in one place. Standing workstations for IT people. And soleus push-ups. Actually, if you can do that, soleus muscle can be used. Even in our clinics, whenever we remember, push up the soleus while sitting, then you are working out the bigger muscle of the body. So it will help you do other things. So sitting is akin to smoking. Even for us as doctors, move around after half an hour. Take a walk, 15 steps takes about 8 seconds. So you can definitely have that much time. Periodontitis, this young man, 36 years old farmer from North Maharashtra, very wiry, hard-working fellow, triple vessel disease, had to go for surgery. Nothing else, no diabetes, no tobacco, nothing, but just periodontitis. There is evidence related to that I just want to skip and go forward. Frailty is definitely something which we must remember now. A typically frail looking man like this has lost all his shall we say, pad of fat here and starts looking frail. And the biggest part of the frailty is sarcopenia. They lose muscle, and that's why they become frail, and then they fall down and they develop myocardial infarction, strokes, and other. Totally preventable, totally preventable. And you know what's the first step for preventing frailty? Eating a meal every day with the family. This comes from scientific books. It's not my own creation. So all that you have to do is include them in the family. Don't make them a recluse or don't relegate them to one room. I think that will prevent frailty. Avoid large dose of statins in them. You are already a sarcopenic patient. So be practical about these patients. Feed them well. In fact, saturated fat needs to be given to these people when they are getting frail. Heart rate and mortality in healthy men, you can see that lower is the heart rate, better is the mortality. I don't know how these studies are conducted. Look at this study, Netherlands apparently. Resting and exercise heart rate measured in 5,000 men were suspected to have CVD. Follow-up was 23 years. And we finished this slide in 5 seconds and 10 seconds, but huge research which goes on. But please pay a thought for this. Reduce the heart rate, your own heart rate. And I don't know whether beta blockers reducing heart rate helps the patient or not. But naturally reducing will help. That is by way of meditation, yoga, and other things which have been discussing a lot. Aerobic exercise, yoga, meditation, mind management, and maybe beta blockers are important. Now, primary prevention obviously has cardiovascular health benefits, followed for at least 50 years of age. And there are, clearly it is a better prevention. Somebody undergoes a primary prevention is much better off compared to those who do not follow this. The longer survival, more than 11 years in men and more than 8 years in women, if you give them good primary prevention. Heart healthy diet, lot of controversies related to that. But I want you to read this extra reading in this slide. It was JACC 2017, and this is from the American Heart Association, and it gives very clearly harm, borderline recommended, and add to it Indian masala, and probably you will be giving them good diet for your own patients and for yourself also. It says that plant proteins are the best amongst the proteins. Combination of aerobic and resistance training is required. I'm showing my photograph not because of showing off, but I could only find this one. So it means that you are keeping your muscles intact. Keeping your muscles intact makes a lot of difference to overall health, especially the degenerative diseases which come later. So drugs for primary prevention, secondary prevention, here. Statins, combination of bempedoic acid, ezetimibe. Suppose somebody's LDL levels are 145, 150, and he is a 45-year-old. Then what do? I think you have to reduce that LDL level to below 100. And suppose he is a metabolic syndrome type of a person, then my choice becomes a bempedoic acid because it is sugar neutral. So rather than starting a statin, I would start, if you find bempedoic acid is not powerful enough, add ezetimibe to it. But reduce the LDL and probably you will get the... And my also dream or something is that something like inclisiran would be used for primary prevention. One injection and then it is done if it becomes cheap enough. CKD has to be used for SGLT2 is a must because it prevents CKD. And patients who are adherent to low risk, suppose, look at this. Somebody who is less than 40% medicines and more than 80% medicine, the difference in the CV events is more than 50%. So those who are adherent to your medicines are likely to be better off as compared to cardiovascular events. We are again talking primary prevention. So in fact, non-adherence is considered a new risk factor in the atherosclerotic disease. So that's why this somebody called N.J. Wald came with the hypothesis of polypill. He said that, okay, so many aspirin and other things are ramipril, they're reducing the events so much. Why not combine them? Hypothetically, it will lead to 80% prevention of primary events. So that's why the concept of polypill came into picture. I do that. Like suppose he's a villager, a farmer comes to me, he's hypertensive, tobacco is his way of life, and he's non-exercise, he's just working in the fields. If I give him 4 drugs, this, that, he's not going to take it. So I still stick to our old polypill, which little inferior in management, but it works for him because it is giving him good amount of primary prevention. another non-scientific slide, but this is from the WHO. It is a 75 years of follow-up. 4 research teams died during this follow-up, because how many research teams will continue for 75 years? And then they say, for staying alive, health, length, quality of diet depends on the social circle and connection and secure close relationship. Look at the top. Social connections and secure close relationship matter, not your exercise, not your hypertension treatment, nothing else matters much. So it's not something which you can say non-scientific. It's a huge study. So epidemiological, that's why we feel, okay, it's not very scientific. But that's why I feel WhatsApp group are a great thing. Our own old schoolmates, now we meet after 25 years or 30 years, and we have a gala time throughout the day. So it makes a difference if you have a large social circle, and of course the very close emotional family and friends type of a circle. So the social requirements that are required for primary prevention are increase in physical activity, yoga, meditation, strengthen the tobacco control strategies, improve dietary choices, simplified screening procedures of risk factors, and fixed dose combinations for compliance of many. Home BP measurements must be encouraged because it makes a lot of difference in good management of hypertension. So ideal parameters for health and vascular disease are enlisted. I think you know all of them. So secondary prevention importance is well known. It is somebody who has established this thing, cardiovascular disease. So in 2025, I think total cholesterol has lost its importance. Then HDL has lost its importance. Triglyceride maybe, but it is the star is the LDL. You have to, our own one target is LDL and LDL and LDL. If you aim at that and reduce it to low levels in high risk people, you follow the LAI guidelines maybe, and you will find that you will do justice to your patient. And we know that lowest is the best is where we have come now. Very high risk people less than 30, and most ASCVD less than 70 is what we think of. The chronic coronary syndrome is a terminology which was coined in the European Society, and almost 33% of coronary syndromes are in our own practice now, not acute coronary syndrome. So how are they managed? They are managed by preventing events. Actually, it is nothing but prevention of events, that is secondary prevention. And there are some other trials which also support this kind of conservative management for chronic stable disease. The guidelines are completely different. Suppose somebody has an 80% lesion in the right coronary artery, acute coronary syndrome, no doubt you have to stent it. Chronic coronary syndrome, you may have to wait and treat him on medical treatment. So that's kind of a difference is possible. Because chronic coronary syndrome, if you leave on good medical treatment, there is about 5%, 6% chance of getting an event in 1 year. And if you put one stent, the risk level is also so much. So it's not a great difference except for symptomatic management. So if we look at these ACC-AHA management of stable ischemic heart disease, most of the things are known. So it is said that it is the most preventable disease. One of the most preventable diseases is the cancer which happens because of smoking. So if you don't smoke, you don't get that cancer. But the second most preventable disease is second heart attack. So if you really work on your patients, then you can be a winner by preventing him his hospitalization, expenses, and so many other things. So the COMPASS trial thought that why not in these patients give rivaroxaban instead of the second antiplatelet agent, which was anyway overused. So if you have somebody who has 65 and above, diabetic, ASCVD, polyvascular disease, that means he has coronary disease, carotid disease, peripheral artery disease, this probably makes a case for rivaroxaban vascular dose 2.5 milligrams twice a day, but it has not appeared in the guidelines. So I would leave to that only this kind of a subset where one could use, but otherwise I will wait for some more time. So I feel monoclonal antibodies and other things have to be used because there is a reduction of almost 60% reduction in LDL on top of a statin therapy. Such a whopping reduction is not possible with drugs which can cause side effects, and the frequency of inclisiran is also very little. So slowly the use of these things will go on as time goes by. the official winner of Not My Job contest. This man was given a job of painting the side of the road. And because this tree bark was here, he painted around it, saying that it's not my job. So treating coronary artery disease is like that. If you don't prevent, you will get an official winner for this kind of a job. This whole thought process started by Dean Ornish. If you read the book, it is highly unscientific to start with. But the principle is correct. Good lifestyle, it can prevent, is what it says. And then it appeared in the American Journal of Medicine way back in 1998 about non-invasive management and reversal unit. So I'll just be wondering, and just only 10 seconds to go. So if you have, what is reversal of coronary artery disease? If there is no stenosis, hypothetically blood comes here and comes out of 5 lines. 50% stenosis, no change in flow. 75% change, no stenosis. But at a critical juncture from 75 to 80, suddenly there is flow limitation, incidences, angina and other things. So if you reverse from 80 to 75, suddenly you will get more flow. Your stress thalliums will be normal. So this kind of a reversal, mini reversal, makes a huge difference because the flow dynamics is such that flow is dependent on the 4th power of the diameter. So if you increase the diameter a little bit, it will help a lot. I think I'll go to the last slide now. Okay, from birth to natural death, if you draw a line, a triple vessel disease leads to premature death, but a good maybe bypass surgery brings him back. A double vessel disease leading to premature death, a good angioplasty does that. Let the interventionalist and cardiac surgeon do this part. It is a major change in a small community. But what we have to do as clinicians is prevention and prevention and prevention. You follow the principles, patient will go to his natural death without undergoing any other things. Thank you.
Thank you, sir.
Excellent talk as always, Dr. Hiremath. I think the session is open for questions, comments. I'm very sure there'll be many points and questions.
I thought keynote address, there were no questions.
Of late, we have come across so many cases or increased incidences of sudden young cardiac death.
Next talk. I think leave it to Dr. Yashlokan. Next talk.
Do you recommend, you said that prevalent hypercholesterolemia can go ahead with what about primary prevention? Still go ahead with that or?
See, all the inclisiran evolocumab trials are in secondary prevention. There is no evidence. But my, shall we say, utopic view of turning the tide, it's not there, is where you should have a genetic mix. And a time will come when we'll give you one injection for 6 months. And then will be no medicines, nothing. So that will work for primary prevention if there is some more research. If primary prevention is going to come through LDL reduction, why not? Logically, it seems okay. And the frequency is once in 6 months. I think it will add a lot of to these things. So primary prevention also would be possible, but one would wait for evidence to come. Yeah. Actually, I got your question. CT coronary angio or calcium score has to be used much more than what we are using today. I'll give you one example. A 50-year-old undergoes an executive checkup. His LDL, this sense, everything is normal and his stress test is negative. So what do? You leave him on nothing, no aspirin, no statin, nothing. And after 1 year, he comes back with a myocardial infarction because he had a 50% lesion and he had a calcium score of 58, 59. And because you did not give him secondary prevention, he can get into an event. So our thinking should be to do anatomical thinking first. Get the CT angio done first. Suppose the CT angio is clean, then it's a difference. Suppose the CT angio shows mild disease, some calcium, put them on secondary prevention and then follow them up with hemodynamic testing. That means every year, suppose he does a stress test. If it is normal, that means we know that the block hasn't worsened. So that is how we should, in the hierarchy now, CT angio has gone higher up. It could be the first one to look at coronary arteries. I don't differentiate. When our center, everything is the same. CT angio and CT Everything is done at one go only. I don't know, very little difference.
Thank you, sir, for some eye-opening facts that you gave just now. I wanted to know your experience about PCSK9 inhibitors. Last 1 year, have you used, and or any other cardiologist here? How is the experience?
It's phenomenal. I mean, there is just no doubt about the efficacy of the drug. Indian patients, inclisiran and evolocumab, we have been using very often. And the results are dramatic. We've had patients with LDL of 10 and other things. So we don't want to be 10, but it can happen that it is so powerful that it can do that. So there is practically no side effects. Practically, except for injection site thing, there is nothing at all. So if somebody can afford it right now, I'm inclined to use it rather than not use it. Yes, sir.
Yeah,
No. Of course, basic statin will be there.
just adding one point to what he said is, see, the values of LDL cholesterol and non-HDL cholesterol to be brought down for secondary preventions are so low now. Say we are talking about 30, and that really works. So reaching to 30 LDL is next to impossible in more than 50% patients with whatever oral medications you take. So many of my patients are on fullest dose of statin, ezetimibe, and bempedoic, all three together, and still they are having 65, 70. So there is a huge need of this molecule. There are many patients of mine at my institute who are on inclisiran. Unfortunately, though the previous drug, PCSK9 monoclonal antibodies, have got good data in secondary prevention even of CVOT, but since it's twice a month and the cost is little higher, many of my patients have been now placed to inclisiran. It's a wonderful molecule, almost devoid of any side effect, and it has amazing power and potential to reduce a huge burden of events and interventions.
Just like the Ernie talk, you can't give 80 milligrams of atorvastatin in everyone, 40 milligrams. They may not be tolerating at all. So in those cases also, I'm resorting to.
Dr. Anish, in those patients, you stop statins and rest of the things,
No,
right?
no.
You continue the
You cannot,
best things.
because see,
Yes.
statins are 35 years old drugs. They are Amitabh Bachchan, extremely proven, and they have to be used. This is on top of that.
Yes.
So best possible dose which is tolerated by patient of statin should be used.
You attain the goal and you have a powerful thing to attain.
Sir, excellent talk. And the summary and the take-home message from your talk is that target LDL only. The villain of the talk is LDL only. So my question is, irrespective of the age, irrespective of the patient having existing comorbidity or some other metabolic issues or not, see, can we approach as a clinician of all LDL above 140 or 135 by medical treatment besides lifestyle modifications?
Yeah. Suppose somebody doesn't have a big risk, then you have to bring them down to 100. Average Indian adult should have a LDL value of 100. And those who are ASCVD can come down to 55, and those are very high risk 30. So as you said, yes, suppose you are treating somebody and LDL value is more than 145 persistently, then I would use statin to bring it down to 100. Use LAI guidelines. I think they are good guidelines.
Yeah, but sir, what we observe that in spite of aggressive exercise or regular walking, stability of the weight and all that,
It doesn't
we
happen.
have observed that LDL remain around 135-40. So
You have
can
to
we give
use
a
a
statin
statin.
in that group of patients?
Absolutely.
Just for primary prevention?
No doubt. No doubt.
Even
As-
though coronary calcium score is zero.
Zero, yes. Primary prevention now, statin has gone ahead of aspirin.
So the conclusive remark is that irrespective of even calcium score is zero, patient is doing active lifestyle and controlling everything, even though LDL is persistent 140, we should give statin.
Absolutely.
So just adding one point to that is, see, LDL cholesterol is modifiable by 15 to 20% tune whatever you do. Somebody doing fasting also and exercising 5 hours a day, LDL is not modifiable by more than 15 to 20%. Now, this is most important concept, which we need to talk to the patients, number one. Number two, the concept of exposure of LDL years has become so much valid and practically relevant that somebody, say for example, in spite of doing everything and having calcium score 0, but having LDL of 135, 140, if he is exposed to that level of LDL, sooner or later, he or she is going to have atherosclerosis and events. So in India, if you want to attack, I personally believe everybody in my life, latest by the age of 15 years, lipid profile with lipoprotein A must have been done. No Indian should be left alone without lipid profile lipoprotein A by the age of 15 years, because you will find 5 to 10% people even in that zone whose levels are very bad, either lipoprotein A or cholesterol. Maybe see at that stage you may not start medicine at stage 1, but then you can be conscious on lifestyle, and those are the people who are to be followed rigorously. And early institution of lipid lowering therapy is a must.
And
Anish
the-
has already made the point of LPA. Sir, all these drugs, statins, and they do not lower the LPA. So probably that is where inclisiran and PCSK would have a role.
LPA is still an enigma. That means by lowering LPA, whether you make good benefit to the patient or not, we don't know. But it definitely gives you a propensity of genetic propensity of that individual to develop atherosclerosis. So it is said that you do LPA at least once in lifetime. Once you do that, and if it is normal, then don't repeat it. But if it is high, then your aim is to reduce LDL to the desired levels, whether it
So-
requires a statin or not.
Maybe adding 1 or 2 points to that. Lipoprotein A is a risk multiplier. So when you calculate risk by other parameters, and if lipoprotein A is less than 30, the risk calculated is okay. But if lipoprotein A is high, it multiplies the risk by 1.5 to 3 times, number one. Number two, inclisiran does reduce lipoprotein A, but to have any meaningful, as far as cardiovascular event is concerned, we need to reduce LPA by 80 to 100%. So inclisiran reduces LPA by 20 to 30%. So that's why even monoclonal antibodies, they say that all the benefits are purely because of LDL cholesterol reduction, and you should not extrapolate that it is because of lipo A. There are multiple trials with injectable and one with oral medicines going on. By 2026, we'll have trials of medicines and injections which are reducing lipoprotein A by 80 to 90%, whether they reduce CVOT or not. Till then, a wonderful thing about if you live a lifestyle where Dr. Hiremath talked, and I know that many people live that way, you reduce the impact of lipoprotein A on your cardiovascular risk. And secondly, even if your LDL is normal and blood pressure is normal, you reduce your LDL by 40 to 60 milligram, whatever the level is. Suppose your LDL is 80, bring it down to 40 and reduce your blood pressure by 10 millimeter of mercury, irrespective of blood pressure is, if you can tolerate. It can reduce and eliminate the factor of lipoprotein A risk. So till we get a medicine, we have these two measures.
The last question. Irrespective of the LDL value, can we give statin to all the patient above age of 50?
No, if it is not, if
primary
it is
prevention,
if
justifying
it
or
is
not?
if it is around 100, why do you want to give it?
There is no benefit.
Thank you, everyone.